treatment and the treatment algorithms for CFD for each classification, because it's slightly different for each classification, and there's more classifications that are being added. Why? Because when you know more, you figure out more, right? So they don't always present. There's some that are more rare than others. And since this slide, I believe there's a type 4A. So you don't need to know, this is beyond the scope of this lecture for you to understand all about those. But what I want you to understand is that when he develops his classifications, they are based on how to reconstruct. There's also a classification, the Aiken system, which was based solely on the radiologic findings, like how much shorter was the femur than the other, and they were really based on amputation. So we obviously don't use that one. CFD treatment, as I said, is based on the Paley classification and the parent's decision. I said that earlier. Very severe cases, we still may recommend amputation. There are some that are very, very severe, and in order to reconstruct it, it would take so many surgeries that we feel that amputation is a better option. However, we also present the reconstructive option, and the parents and the family makes the decision. There are some cultures that are very, very adverse to amputation. We work a lot with the Middle Eastern cultures and the Muslim community, and they're very, in general, adverse to that. And also we work a lot with Hasidic Jewish and ultra-Orthodox Jews. They're more open to it, but they're still more resistant than some other cultures. We work also with countries throughout the world. There are some that are more open to it than others. There's another option also for a very severe case of CFD, and that's a rotationplasty. We have a variety of cases in here for that. And then also the reconstruction and the lengthening. For the reconstruction to occur, you have to have a couple things in place. And this is not just for CFD, this is for whatever bony segment you're going to lengthen. You have to have stability at the joint above, and you have to have stability at the joint below. If you do not, as you lengthen that bone, the soft tissues get dragged along with it, and they get extremely tight. And they can dislocate, if it's CFD, they can dislocate the hip or it can dislocate the knee. You must start with stable joints. So these kids, if they come to us as children, undergo, we call it a super hip or a super knee. It's really the stabilization process, and it changes based on which joints are unstable and what type of CFD they have. So if they have a type 1, it's one thing. If they have a type 1A, it's slightly different. If they have a type 2 or a type 2A or B, it's different. And those are the classifications go in severity to, like 1A is the most benign, if you can say that, where like type 3 is, that's more, 3 or 4 is more where you're gonna say amputation. But not always. Okay, so the stabilization surgery occurs at around 18 months. It can certainly occur later. We've had some adults that have come to us with neglected CFD that never had any treatment, and they have undergone the treatment as an adult. And it's pretty impressive. And then the lengthening can occur after about 18 months of healing after the stabilization surgery, and those are episodic, depending on the leg length discrepancy. Okay, during the lengthening, our main goal is to elongate the soft tissue to accommodate bone growth. Because you can be growing up to 4 inches in a segment, and you grow at about 1 millimeter per day. That's pretty fast. Physiologically, you're not going to grow that fast. And we have to elongate that soft tissue so that the hamstrings don't get so tight that they dislocate the knee, or the adductors don't get so tight that they dislocate the hip. It's something we watch every single session, and the families are also doing stretches and range of motion 3 times a day, in addition to the daily PT that they get with us. You also have to be splinting to prevent knee flexion contracture. You have to concentrate on pain management, active and passive range of motion, gait, brace training, parent instruction for home program, which we just talked about. They are going to do stretches 3 times a day with their child. All right, so I'm going to go into our first case study. This is a little girl who is now graduated high school, but this was her when she came to us for her first lengthening. She was a type 1B. I'm not going to go into great detail as to why that's different from an A, just know that it is. It's a little bit more severe. I will also point out that you can, well, let's go to the next slide, you can see better. This was her birth slide. So they knew at birth. They did not know from ultrasound. Sometimes they do. Now things are more advanced than they were back when she was in utero. A lot of the kids know in advance, or a lot of the families know in advance. Okay, so now you see she's 4 months old here, and you see that they're not growing at the same rate, right? And she's 11 months old here, and you see that discrepancy increasing. Okay, so in 2007, she had her super hip. She had that in Baltimore because we were not here yet. Dr. Paley was still up at the Rubin Institute in Baltimore. And if you look at this, this is right before her super hip procedure. One thing I do want to point out, see that nice femoral head there? You don't see it here. It's non-ossified, and that's what makes it a 2B versus a 2A. So she does have a femoral head, but it's not ossified yet. And you also see that her acetabulum is not as well developed as it is on the other side. So she doesn't have good coverage of the non-ossified femoral head. So he puts it in place. He does a variety of osteotomies and a variety of soft tissue releases. You don't need to understand and know all of that right now. Just know that it's all to stabilize that hip and super knee if they need it. I do not believe that she did. Now you can see here, we also use something called bone morphogenic protein. It is an off-label use of it, and it helps to ossify things that are not ossifying. You can also help a patella ossify that's not ossified with some bone morphogenic protein. We also use it in the treatment of Perthes, which is an ischemic disease. So now it's in place, and that is in the OR. I know that because these are the tubes from the OR. Okay, so now let's go back. Okay, I want you to take a second to look at how we're beginning to ossify there. That's pretty cool, right? I'm going to go back just for a second, and how you can see in this one, there's no ossification, right? So what have we done with the super hip procedure? We have put the hip into socket, so now we're getting weight bearing. And what do we know by Wolff's Law?
Put pressure on it, it's gonna
Thank you. Yes. So don't ever forget that. Bones respond to the stresses put upon it. Okay? So now that we're in socket, and now that we're weight bearing, truly weight bearing, and the BMP or the bone morphogenic protein also helps us, kind of like magic fairy dust. So now we're beginning to ossify. And now take just a second to appreciate the growth in that. Right? Now she's getting true weight bearing, and she's beginning to ossify and even grow a little bit faster. By the way, her family had been told the only treatment was amputation. Okay, so this is her a year later. Look at that ossification, she's looking good. She also has fibular hemimelia. It's very mild, and I do not believe that she ever needed a surgery for it, but if you look, the malleoli are pretty equal. They're not supposed to be equal. The lateral malleolus, or the distal portion of the fibula, is supposed to be lower, right, to hold the mortise into place. She did not need treatment for it, but she does have it. So I'm just pointing out a really mild case of fibular hemimelia. We often see that CFD and fibular hemimelia run together. Okay, this is her at, I believe, 3. She came to us, and she was ready for her first lengthening, and she is really cute. She's just showing off the range of motion in her hip and knee. Okay, so she's got great range of motion, hip and knee. And her abduction is good. And she's sassy. Okay, so at the surgery where she had the external fixator applied and her first surgery, she had the removal of the internal fixation, okay? And she had the application of an external fixator, which was called a MRS, modular rail system at the time. Now that's antiquated in our practice. There are other practices around the world that still use it, but we use a different system now, which is more advanced. So she had it applied to the right femur and the tibia. So we cross the knee to help with the knee stability. All right, that's why it crosses the knee. She also had the osteoplasty for lengthening. That's a way of saying cutting the bone in a special way to the right femur. She had Botox injections in the right quadriceps, and she had an arthrogram of the right knee. So they injected dye into the knee to find the axis of rotation perfect, so that they can put the axis of the hinge of the knee joint on the fixator in alignment with that. So everything you're doing is to preserve excellent joint motion, okay, and stability. So this is what it looks like in an X-ray. Have any of you guys ever seen an external rotation or an external fixator on a real person? Good. Okay. In pictures or in vivo?
In person.
In person? Yay. Okay. Good. Super. So that's what she looked like. She did not totally separate, so she had a pre-consolidation. Sometimes the periosteum doesn't separate like it should, and it pre-consolidates, and the only way you know that is at the 2-week follow-up. We follow up every 2 weeks with x-rays and a doctor's appointment for the kids or the adults in their active lengthening phase. So she was coming to therapy daily. It was going really easy because it wasn't separating yet. So she had to go back to the OR and have another osteotomy. And then now you begin to see that bone distraction gap. Okay. And it's growing. And, oh, I can't see well. That one's really hard to see, the second one. But the third one, you can see it very nicely here. Okay, I know as you guys look at it, it's like, what's up there? That's just a lot of hardware. But your eye gets trained to see exactly what you're looking at. Okay, so now she's finished her lengthening. She's gained 6 centimeters, and she's now consolidating. So the ratio of lengthening to consolidation for a child is about 1-to-1. So if it took them 3 months to distract, they're going to take about 3 months to consolidate. It's not written in stone, but that's about what it is. For an adult that's undergoing lengthening and they distract for 3 months, they're going to need about 6 months to consolidate. Okay, so in about, I don't know how many months, I'm sorry, but in a long time after she consolidated, she's back for the removal, and you can see that she's bridged on one side, and she went to the OR, she had the frame removed, and then she had a rod in the femur to help decrease the risk of fracture afterwards and provide better stability. So she went home and she resumed her life and resumed the life of the child, and then we know that that bone is not going to grow at the same rate. So as she left, her feet were on the ground. But as she went away and came back, she's now 3 centimeters shorter. So we knew that she was going to need sequential lengthenings. We knew this. And there is a formula that you can use to predict the limb length discrepancy. There's actually, it's called the Paley Growth app, and you can get it on your phone, and that can help predicts very well the limb length discrepancy that that particular child was going to have. Okay, so she came back. She was ready to have the removal of the IM rod, and she was going to have, by this time, we had a precise intramedullary rod, lengthening rod. It's telescoping, and it's activated with an external remote control. That's pretty cool. So she was the youngest child or the youngest patient at that point in time. Now we do them on super little kids, but this was in 2011. We had started implanting them in 2011. So she was one of our first to get it as a child. We started with adults. And so she had the Precise, and you can see it's an IM device. It's stabilized above and below. She also has, remember I talked about guided growth? Remember I talked about the hemiepiphysiodesis? We'll get to it in better detail later, but if you look at it, she's got some valgus in that distal femur. So we can guide that growth, and that's what this is. I'll explain more about that later, but just that's what those are. So the Precise nail is this, with the 2 screws for stabilization above and below. And then there's your osteotomy, and it's getting bigger because she's lengthening. Okay, so at 6 weeks, she began to sublux her hip. Despite all the measures and despite getting daily therapy, her adductors became very, very tight, and she began to become uncovered. See the difference from here to here. So at that point, we stopped the lengthening. We sent her back home because why? Because you never ever sacrifice joints for length. All right, you can come back and you can do it later. There's a lot of different things you can do at this point in time. Now, being further down the road and having more knowledge with this type of device than we did back then, there's probably another way we would have handled it. But it worked out just fine. She stopped, she was disappointed, her family was disappointed. They wanted to get all their length in that one summer, but she went home, she consolidated, she stretched and stretched and stretched, and then she came back the next summer and she finished her lengthening, okay? So where is she now? She opted, okay, she got her length. She opted, see she has a 3 centimeter lift because she's grown even more. She had, this is, remember I talked about a hemiepiphysiodesis. Hemi means partial or half. And epiphysiodesis, so that means, and who knows what the physis is? It's another word for growth plate. So hemiepiphysiodesis, you're tethering half of the growth plate. And here, we're stopping the growth in her unaffected side. How would we do that? It's one of the tools that we have to equalize leg length, okay? So instead of her coming back and having another lengthening, she and her family chose to, they had 2 lengthenings in the affected side, and they chose to stop the growth at a particular time because we can predict what her leg length discrepancy will be. So she only needed 2 lengthenings and 1 epiphysiodesis or growth stoppage in the other side. Okay, so where is she now? Now, this child was told, this family was told, oh, sorry, that the only option was amputation. Can you imagine? I mean, amputation's not terrible. They're great prosthetics, but it doesn't equal this, right? So that is her, I think she was in middle school. She's now a senior in high school or just graduated, I don't know, I don't remember. But amazing. Okay, so now let's go back and revisit this sweet little girl who has not finished her treatment yet, but she's at a pretty good spot. So just take a moment to synthesize that, okay? And now, Mom sent me this last year when I was doing this. She's gonna be coming back this summer for her final lengthening. She's in high school.
Wherever you release, that's where it's gonna go.
She's a normal kid. She's got a slightly short leg. I mean, I gotta say, when Mom said me that, I was blown away. Blown away. And it never gets old for me. It never gets old for me. It's always so cool. Oh, sorry. That's her. And that's her sister in the water. They also moved to Florida. Actually, I said that in the beginning, right? Same family. Okay. She's swimming. She's doing all the things a kid should do. All right. So this is a more severe case. This is also CFD. This is a rotationplasty. So Dr. Paley recommended a rotationplasty. The family accepted that as an option. Have you guys ever read about rotationplasty? Okay, so you understand that we're rotating the leg 180 degrees so that so there are different types of rotationplasties. This one, they are fusing the femur to the pelvis. So that is the Paley Brown type rotationplasty. And then the knee becomes the hip, all right? So in this type of rotationplasty, you're not gonna be doing any abduction, adduction, or rotation because it is fused, and then the hip is actually the hinge joint, which is the knee. And why would you do that? Think about that shoe lift on that sweet little girl. What muscle is going to pull her toes up, her foot up, to get that, to clear the floor? Tiband, right? That's a small muscle, right? Think about if you flip it around, what ankle muscle, because your ankle is now your new knee, is going to advance it? Your gastroc and your soleus. Okay, so that's a much more powerful muscle, and it's a much larger muscle, and it works very well for that. And that's the whole reason they do it. So this is a child that came back. This was quite a few years ago, sorry. Oh, sorry. This is a child that came back to us, and she had just been allowed to move it. It had been in a brace for 3 months. And so we had to start working on rewiring her brain. Okay? We do it a little differently now. We start movement within a week. But that was 3 months at that point in time.
Restore a lot of the mobility.
This is a young man that came back, and this was about 6 weeks after he was cleared to weight air, and after he got his prosthetic. So he's just learning. And this is him as a senior in high school. This guy went on to actually run, and I know he did some 5Ks, and I think he did a 10K. I don't really recommend that for this. I would say let's go into other sports. But you know, I was told something when I was in PT school. We used to have to go to the APTA conferences, and one of the guys that was up talking, I think he had MS, and he was telling me what type of power each of you have with your patients, and you can crush them with a look, or well, you can't do that, or a judgment, or you can build them and let them grow. So that stuck with me, and I try not to limit my patients. I do say, hey, they're great sports, aquatics and swimming, and that's a great sport, and if they want to run, I'm not going to say don't ever run, unless it's totally contraindicated. But we do have great power, and I've been surprised by patients so many times. And had I limited them with what I thought they were going to be able to do, it would have been a disservice. So remember the power you have and let them fly. Guide them, but let them fly. And when you become a parent, remember that same. advice. This is a little girl that came to us from Poland, and this is about a week after she got her first prosthetic.
Very good.
By the way, the prosthetics for the rotationplasty are really challenging. We started out using a vendor in West Palm Beach, and now we have our own department. And our own department is relatively new. We've been in, the prosthetics and orthotics department's been in place about 2 years. They are wizards with orthotics and braces and AFOs and HKFOs. They're wizards with that. They're still perfecting the art of the prosthetic for rotationplasty. There's a place in Orlando. They're very good. They're better than your average bear, but they're new to that, okay? The place in Orlando is called POA, and if you ever have a patient that is a really hard fit for prosthetics, POA is your place. Okay, so, all right, this is that little girl about 3 weeks later. And now she's kicking it on her own. This is that little girl a month later. Okay. All right, and this is a kiddo that had his rotationplasty back in 2009, our first year, and he had the type where it is fused to the hip. So now we've done, do you guys hear that? You don't hear that, do you?
About 800 feet.
That's okay, so I'll just talk over it. He came back to me the same week that we host our conference. So by the way, I created a conference back in 2011 to help teach people how to do limb lengthening rehab and deformity correction rehab, because it was extremely challenging, and I want to avoid other people having to go through what we went through when we first opened. It's now an international conference that we do annually, and this year we had folks from Italy, we had a brigade from Italy, we had Canada, we had UAE, another one, but I don't remember, and then people from the US. So this is that same patient learning to go up and down the hill. Well, not learning, just kind of showing me what he could do. So what I was doing, this was probably his last visit to our center for many years, because he's from the Hasidic community, he's in yeshiva, he's gonna go on, he's gonna get married probably in about a year, and he's gonna go on with his life. So what I want to do is now teach them, like, how do you live long-term with this? Because he's got some deficits. He's gonna have some deficits. His knee is not like yours and mine. It's his ankle, right? And his family was really resistant to letting him use a cane. And I'm like, our goal is that he keeps moving. Our goal is that he goes out there and joins his friends. Our goal is that he's able, and he's from a walkable community, okay? And that he's able to go out and walk those distances with his friends. If he needs a cane to do it, that's okay. And another thing I was telling the family, which I try to tell all families in a very sensitive way, because it's a sensitive subject, but weight and overweight is the enemy of somebody with these problems. It's hard, if we put on 30 pounds, it's harder to move. If somebody with these orthopedic problems puts on 30, 40, 50 pounds, it's paralyzing, and they can absolutely lose their mobility. So that's one of the things I was saying, is that you want him to move. Because if he stops moving, folks that aren't moving have a propensity to become a bit heavier, and that is the enemy of mobility for him and for this population. So I try and present it in a way as to it is very, very destabilizing to put on weight for these folks. Not at all in judgment, because all bodies are great, whatever size they are, but unfortunately, if you've got an orthopedic issue, it's very, very, very difficult to be as mobile. Okay, now this is a kid from Israel who had osteosarcoma. And so he has an entirely different type of rotationplasty. He has a femoral head and femoral neck and acetabulum. And the mid shaft of his his femur was removed because of his cancer. So they fused the tibia to the upper portion of the femur and left the femoral head and the acetabulum in place. So what can he do that the other ones can't do?
Abduct.
Abduct. He can do all the normal things that a hip can do. He's got a very healthy hip. He comes to us from Israel.
So focus, everything, think about your right leg, okay? Out, 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 out. Come back to the middle.
This is a red cord. It's
Right.
like a bungee
And
type
out.
system.
So that's the better.
And you can work somebody who's not allowed to weight bear
Out,
yet
well done.
with this system.
Good. Again.
Okay.
Down.
So this is him.
Got your right.
Sorry.
Keep that right butt cheek.
No way.
Good.
I tell you, technology never ceases to amaze me. Those both came from my phone. And it plays on my computer, it played before. Okay, so we're just gonna say he was kicking the ball and running around. It was really quite impressive. And I reached out to him after the October 7th attack in Jerusalem, or in Israel, and I reached out to a lot of my patients, and how are you okay, really worried about him, and we've kept in touch. It's really amazing. He's doing great things, he's safe, and he's living his best life, and so, other than what's going on in his country, but he's actually in a different country right now. But what I'm saying is they can go on and they can have really normal lives. And what they're going through is tough, but I will say we've actually done a study with Nova Southeastern University Psych D program, because I will say in the early years I was very concerned that we were giving these kids PTSD, and I said we've got to do this better, and I reached out to a variety of programs, and Nova's program came right in, and we created a training program for our therapists to approach the kids and the families at their level. We created a support program for the children and for the parents to help them with their emotional needs, because this is a hard process. This is not easy, and it's painful, and it's hard. It's not easy. But so they did a study after implementation of the program, and they found that a significant amount of kids who have gone through this actually experience post-traumatic growth. Let that sink in. They feel more able to go through adverse situations and come through them well than they did before they've gone through this. Now, I'm not saying that we want them to go through this. We don't. We want them to go through whatever they need to go through. But these kids are going to go through something, whether it's amputation, whether it's limb lengthening. They're going to have things to deal with. But going through adversity has made many of them feel more confident in their ability to handle other aspects of their life. All right, fibular hemimelia. It's a congenital axial fibular deficiency in which the fibula is shortened or absent, and it may include a terminal deficiency at the foot. What does that mean? A terminal deficiency at the foot. So it means that when these kids were developing, they were not reading Gray's Anatomy. They don't always have all the bones. They often have less digits than the other foot. Okay. So the incidence is about 1 in 40,000. It's much more common than the next one that we're going to go over. And as I said before, it often comes with CFT. So the classifications, again, there's a classification from Dr. Paley that is based on reconstruction. It talks about stabilizing the joint above and below and the surgeries that you need for each different classification. The other ones are more geared towards amputation. So there are multiple classifications. Again, beyond the scope of this lecture, okay? The most common option given to parents, again, is amputation. To be fit with a prosthetic, they recommend an amputation around 12 months and to get a prosthetic as soon as that's healed, and then they'll get a new one every year. I'm not saying that's a terrible one, it's just give the family all the options. Because that is a final one, right? It is not something you can go back on if you now learn at 2 years old, oh, I could have reconstructed, right? So, most of those patients do very well with limb reconstruction. The surgery is based on the Paley classification. We have a super ankle, which means a stabilization for the ankle, and it changes slightly with the severity of the fibular hemimelia. The PT, again, focuses, right after this, by the way, let me back up for a second. After the stabilization surgery, they have to heal, so it's about 6 weeks where they're not weight bearing, but we're usually doing passive range of motion to begin at post-op week 1. Gentle, because we don't want the joint to become stiff, whether it's at the hip, knee, or the ankle, all right? So, and oftentimes, depending, like with the super ankles, they will often, will give them a few visits, and the parents will be gently moving that ankle, and then they'll go back home. And they'll come back once they've healed and are ready to begin weight bearing. All right, so the PT during lengthening then is to grow the soft tissue, all right, to accommodate the bone growth. And also to teach them proper gait, to teach them how to deal with their precautions. If they have a precise nail, they're gonna have weight-bearing precautions. If they have an external fixator, they're typically weight-bearing is tolerated. I do want to take just a moment to say, so the old precise nails were limited to 25 pounds if it's extramedullary, 50 pounds if it was intramedullary for the tibia, and for the larger nail in the femur, 75 pounds. That said, they have just come out with a Precise Max. It's on short supply right now, so we implanted our first one 2 weeks ago. We implanted, I think, 8, and then there's a shortage on the market. So we've got folks that are waiting for that Precise Max. That is a full weight-bearing nail, a fully weight-bearing nail. And those folks are able to, there's a 150-pound limit for the smaller nail. That's going to go into a smaller patient. For most of those patients, that's full weight bearing. Although full weight bearing does not mean you can run and jump. Full weight bearing means that you can walk, maybe with a cane for stability, so that you don't have a fall, because that's not what we want. But you can bear weight on that without using a walker or bilateral crutches once you're stable and you're past the pain free. That will be on the market. It's on the market, but it's just in short supply. So we were the first center in the US to implant that. And, all right, this is a child with fibular hemimelia. He was adopted from China. His mom and dad were in healthcare. They knew when they adopted him, or they were told when they adopted him, that he was going to need an amputation. They had already planned for that. They actually lived in West Palm Beach, Florida, and they found our center, and she thought, I'll go. I don't think that's going to happen, but I'll go. And they decided to go the reconstruction route. So this was his leg prior to. He had a 7-centimeter discrepancy. It is both in the femur, and he has a total absence of a fibula. Now, something else you notice there is the instability, right? You also notice how it's not growing straight, because the fibula and the tibia guide each other, okay? So, in the OR, they are aligning the ankle, so they're doing the super ankle in the OR. Also, let's go back for just 1 second. Look at the instability of that. So they're getting bony stability, and they're releasing the contractures, so that now we have alignment, okay? This is all in the OR, and then they're applying the fixator, and they're creating the osteotomies to begin 2 things: deformity correction, So they'll do the osteotomy at the apex of the curve in the bone. And they'll also do the osteotomy for lengthening. Sometimes it's the same osteotomy, sometimes it needs to be a double level osteotomy. Again, kind of beyond the scope of this lecture. But, so you can see how they did the osteotomy to correct the deformity of the femur. You see that? And again, I know you look up there and it's just a lot of metal, but I'm trying to point out for you guys. And then, right here is the osteotomy for his tibia. All right, so now he is lengthening, and now you can see the distraction gap there. Everybody see that? Okay, good. So he's lengthening and correcting at the same time. Let's take 1 second to say this is the modular rail, meaning it's external, and it's correcting growth, or it's correcting deformity into lengthening, and they can do a little bit of valgus varus correction, but not a whole lot. This is incredibly impressive. It's a computer dependent, so the surgeon puts in all the angles and deformities, and the computer spits out a program on how to turn the struts. And it can just, it can correct deformity on 6 axes. So it can correct medial lateral, anterior posterior, length, and rotational. It's pretty amazing. Okay, so we're just marching through this kiddo's deformity correction, and he's going on. Now this is at the time of X-fix removal. These are OR pictures. And they rotted his femur, and they removed both the modular rail and the, that's a talar spatial frame. They put him in a cast in knee extension because he had developed a bit of a knee flexion contracture. So in the OR, I think they may have lengthened hamstrings, I don't know, but they got him in max extension. So this is a sweet boy. After everything was said and done, and this was another kiddo. This one came to us from China, but a local kid because he was out. This one came to us from Qatar, and they met in a hall. They were learning to run that day, and this was just a picture that parents snapped and shared with me, and they said we could use it for the lecture at that point in time, and they're just so cute. And so this is him last year. He had been told amputation. And we know he's got a little bit of hip instability. We know he's gonna need to come back and have probably another surgery to stabilize it. But that ain't bad, right? Yeah. Okay, now, let's go to tibial hemimelia. This is much more complicated than what we've seen so far. Tibial hemimelia is a preaxial longitudinal deficiency with varying degrees of absence of the tibia. Some forms are genetically transmitted while others occur sporadically. It often occurs with polydactyly. What is polydactyly?
A bunch of digits.
Extra digits. Okay. This is one of the rarest forms of lower leg deformity with an incidence of 1 in a million. And bilateral tibial hemimelia is about 1 in 3 million. It is one of the most rare forms, okay? Now, at our center, folks don't understand, like patients that come don't understand how rare it is. We had this kiddo that you're gonna see that was in rehab, and I remember the dad said, there was another child that they were playing with that had tibial hemimelia, and the dad said, yeah, it's pretty common, you guys have a lot of them here. And I overheard that and I went, you know, actually it's not common, but it is common here because people come here because the only other option is amputation. So we see it, I mean, literally there have been days where not myself, but there's another therapist that loves treating tibial hemimelia. I treat it for sure, but she said there have been days where that's all she treats all day long is kids with tibial hemimelia. No other therapist in the world can say that. Okay, so there's the Jones classification, the Paley, again, Ours are based on the reconstructive factors, or rather, process. And there's a whole bunch of types of this, and I have to tell you, it is fascinating. It is fascinating to see what comes through the door and to look at the x-rays. So this is a child with left tibial hemimelia, came to us at 3 years old from China, with the father. So this is not an adopted child. So we talked about the polydactyly. You can see there's extra digits there. This was a birth picture. But wait till the next one to really appreciate the extra digits. So what can we take from this x-ray? What can we glean from this? Fibular hemimelia has an axial deficit oftentimes at the foot. So they often have less toes. Okay, and let's also appreciate that there's almost always, there's almost never an always or a never, right? So I've seen kids with fibular hemimelia that have extra toes, but it's very rare. And I've seen kids with tibial hemimelia that have less toes, but it's very rare. So if you have somebody present to you with a short lower limb and extra digits, what do you think, what's your first guess gonna be?
Tibial.
Tibial. If you have somebody present to you with a short lower limb and they have 3 digits, what's your guess gonna be?
Fibular.
Right, okay. But you have to have an x-ray to know, right? So, see how high this fibula is? Okay, the fibula is way up here. And that is a little enlarge of the tibia. But it's really good that that child has that, because that helps for stability of the knee. There are some that have absolutely no tibia, and those are much harder to reconstruct. And really, the fibula in you and me only bears about 2% of the weight. It's not a hugely weight-bearing bone. And it's very thin. What's that law I talked about earlier?
Wolf's Law.
Wolf's Law. Bones respond to the forces put upon it. So when we do the reconstruction and they start weight bearing on it, it thickens up and it becomes to look more like a tibia than a fibula. So we're just going to march you quickly through, again, putting on lots of hardware, lots of jewelry. The first part of this surgery is to pull the fibula down to station so that it's underneath the femur. Back in the day that this patient was seen, typically they did the foot reconstruction at that point in time. And now they're doing it, they're pulling it down, and then they're doing the knee and the foot reconstruction. So, follow-up x-rays, again, pulling it down. See how it's coming down to station? See how it's much closer? And once it's down to station, oops, there we go. Oh, I forgot to say this. Look at the foot now. He had to reconstruct the foot, because he's not going to leave him with all those digits, is to figure out which toe is actually the hallux, which is the large toe. And he has to figure out which one has the EHL on the extensor hallucis longus on it. It's not like you just hack off the most medial toe, right? You have to know what's attached where. So that's how it's determined. Pardon?
Someone sneezed.
Okay. So this is the child after the reconstruction and after the removal. Okay, let's take a moment to say, anybody have any idea what that is? Yes. I'm not telling you until you guess. Let's go back. Look at the x-rays. Okay, let's go forward.
Was the holes from the fixation?
Yes. So those are where the pins were. I don't know who said it, but very good. Those are where the pins were. Very good. Now, that's perforation, right? So they're at risk of fracture post-X-fix removal. So we may be doing some therapy, but we have to be treating that very differently than when they have the fixator on. So what we're going to be doing in the first few weeks post-op is more active and active-assisted range of motion and gravity-assisted range of motion, maybe fingertip assist to get range of motion, but we're not going to be pushing hard. But when they have the fixator on, and we are needing to keep that soft tissue growing to keep up with the bone growth, we're pushing really hard. We're doing everything we can to prepare it using moist heat, active warm-up, active assisted warm-up, soft tissue tools, all of those things. But then we're pushing really hard. Not now, because you can fracture. Okay. Dwarfism, and this is controversial in this country, to lengthen folks with dwarfism. Is defined as short stature of adult height less than 4'10". There's over 200 causes of dwarfism. The most common is achondroplasia. These three are types of dwarfism that we typically can lengthen. Not to say that we don't lengthen the other ones. We often see other types of dwarfism for deformity correction because their bones typically don't grow straight and don't grow stable. And each type of dwarfism has a different type of deformity that tends to come with it. And I say tends because there's never and always and never and ever. Okay? So achondroplasia is the most common. Hypochondroplasia is less severe, and pseudoachondroplasia is quite severe. That comes with a lot of deformity. Folks with achondroplasia, the most common one, typically have a normal length trunk, and the extremities are shorter. Hypochondroplasia, folks with that tend to be more proportioned, and pseudoachondroplasia comes with all sorts of deformities and often scoliosis. Folks with achondroplasia often develop spinal stenosis. Okay, so let's talk about a life plan for dwarfism. If they choose that they want to go the lengthening route, their first lower extremity, and it's a 4-segment lengthening, meaning bilateral femurs, bilateral tib fib, 4 segments. So their first one is at about 8 years old. It can be later, it can certainly be later. They could choose not to lengthen, that's all fine. But I'm saying if they go this route and they go with the most early that they can go, it's about 8 years old, and it's a 4-segment lengthening. They can get about 13 centimeters or 5 inches in the entire growth of that. So meaning split between the femurs and the tib fib. The subsequent lower extremity lengthenings occur about every 4 years. So 8, 12, 16. And they can get about 15 centimeters or 6 inches in the 4 segments, plus deformity correction during that. Somewhere in the middle of 2 of those lower extremity lengthenings, if they go for all 3, there is an upper extremity lengthening where they get about 5 inches with external fixators. The total life plan, they can get 17 plus inches of growth. Okay, achondroplasia is an autosomal dominant genetic disorder with rhizomelia. Rhizomelia means that the limbs are shorter than the spine. And the average female is about 4.35 inches. I'm sorry, I flipped that. The average male is about 4.35, and the average female is about 4. But it varies greatly. Some of them are teeny tiny, and some of them are a little taller, just like you and I, very greatly. This is a kiddo. His parents waited till he was 12 so that he could decide They didn't want to make the decision for him at 8. At 12, he wanted to undergo the lengthening. He had bilateral, and this was back in the day when we were doing all of those with external fixation. This is the modular rail, so we know from this x-ray that he didn't have a lot of deformity in the upper bone of the femurs. But because he's got the talar spatial frame that corrects deformity on 6 axes, we know he had some deformity to correct on his tib bone. So he gained 6 inches on his first distraction. Then he had his femur rotted and everything removed. He went home, lived his life for a while. That was him status post his first lengthening, which he did at 12. Now, so this is just a little bit of difference. This is not a full body scan, right? And then we got our EOS machine, which is a low dose radiation full body scan. And now you can see the whole body. So it's really great when you're monitoring deformity, okay? So we talked about the rhizomelic changes or the rhizomelic deformation. So look how short his arms are. He's holding his arms like this. All right, that's how you stand in EOS. But where do your arms typically hit? Upper thigh, right? He's holding here. Where am I hitting? Lower rib cage. His are way up there. And so the upper extremity disproportion can become extremely problematic later in life. Our spines, well, I can't say ours anymore. Your spines are quite flexible because you're young, right? And you can bend and you can twist and you can do all those things. As you get older, they get stiffer, even if you do all the right stuff. And especially as therapists, I have to say. I've had back surgery, spinal stenosis. Hope you don't ever need it. Don't be a hero in your first years, okay? Don't blow out those discs. But anyhow, these folks have a very high propensity to get spinal stenosis at any point in their lives, but especially as they get older. So if their arms are very short and their bodies are very long, they can no longer bend and twist to do things like personal hygiene care. They can lose that ability, or they can not have that ability because they're so stiff. So the arm lengthening can be extremely helpful. And especially if they need a spinal fusion because of their spinal stenosis or instability. We just rounded this morning on a young man, I think he's 23, with achondroplasia, with spinal stenosis, was working at a Walmart and lifted something and he lost lower extremity function. So he had an emergency surgery yesterday, and he said it was better this morning, but, and this was not a patient of ours. This is not somebody that's lengthened. This is not somebody that's undergone any deformity correction surgery. This is just the diagnosis of achondroplasia. It comes with its own problems. So, I went on a tangent. I apologize. We'll get through this. Okay, so this is the same guy that we were talking about that had the 4-segment lengthening and got 6 inches. This is now his upper extremity lengthening. That's the distraction phase. This, by the way, is the easiest lengthening. So you have this behemoth on your arm, but you can go about your normal life. And these usually don't have to stay in West Palm Beach at our center the whole time. They do have to come and get set up for their stretches and set up for their therapy, and then we send it all home to their home therapist, and they do their therapy at home, and they fly back every 3 weeks for their x-rays and a follow-up with us, and we progress their program and they go back home. All of the other lengthening patients have to stay at our center for the rehab during the distraction phase. Why? Because a lot can go wrong during the distraction phase. If you don't know what you're looking for, you can't prevent it. If you don't know what you're looking for, you can't catch it early, and a hip can dislocate and you won't have any clue. And even in the best hands, these kids can get tight, or these adults can get tight, and problems can occur. We are constantly looking for prevention of these issues. And we're in constant communication with the doctors as well. If we see that somebody's losing range on their knee extension, we're sending a note over to the doctor. We're texting them saying, hey, so-and-so's lost 20 degrees over the last week. And they're either gonna slow down the lengthening or stop for a few days the lengthening. There's gonna be a change, because we never sacrifice the joint for length. All right, so he had an upper extremity lengthening, and he gained 4.5 inches. And that is, I'm sorry, let me go back. That is right before and after. And these were just his x-rays side by side by side. This is a different child, this is a female. She had her first lengthening with the external fixators. And these are all modular rail systems. So she didn't have a lot of deformity to correct, okay? So she's got external, lateral, and then she's got medial. Why did we put it there? Why would we not put it lateral? It's gonna be really awkward to walk with the medial fixators. Can anybody think? What structure runs right through here?
Oh, through where? Oh, the peroneal?
Yes, good job. The peroneal nerves run right through there. Common peroneal, superficial peroneal. So if you put the fixator right there, and the pens, you can obliterate that. You can create a drop foot. We always medial. So I've taught all over the world. And I go every 4 years to the ALPE convention in Spain, which is, it's kind of like LPA. Have you guys ever heard of Little People of America? Okay. That's the organization for folks with dwarfism. They don't like us at all in this country because they're very anti-lengthening. And, but in Spain and Europe, it's very different. So ALPE is the European version of LPA. And I've presented there. I've had the honor of being asked to present every 4 years for the last 12. And they're pro-patient. Whatever you choose, we will support you. And so they give lots of education on all the different things that are available for the different types of dwarfism. And there are medications now that are available to block the receptors for achondroplasia. Biomarin, Voxigo is the drug company, is Biomarin. And there's some other ones out there. I've always seen them presented in the early trial stages at ALPE. It's really a great, great, great organization. But anyhow, my point is that unfortunately, when they lengthen in Spain, they're putting the lower extremity fixators lateral. And I've seen a lot of drop feet, and that to me is really infuriating because you want the patient to do better after the surgery than they did before, or the same, right? So we do a lot of deformity correction. Out there, unfortunately, they tend to make longer bones, but not particularly straighter bones. So you'll see a lot of valgus, a lot of varus, a lot of drop foot. And to me, that's really frustrating. Like, don't do it if you're not gonna do it right. This is just an example of a young lady that underwent deformity correction. She's now a nurse. She's pretty amazing. And this is her pre and post humeral lengthening. Okay, let's talk about achondroplasia and angular deformity correction during limb lengthening. Again, I've said it multiple times, the goal is not just to be taller, the goal is to have alignment, okay, and stability. And so if you look at this child's knee, if you look at this child's knee prior to her lengthening, it's pretty unstable. But through the process of lengthening and deformity correction, then she becomes much more stable. So, this is called fishtail deformity. It is created by neonatal sepsis or infection. It is a damage to the central growth plate. So the chances of you seeing somebody with this, if you're working in pediatrics, you know, there's a lot of kids that are developed, or rather that are born very early, that are in the NICU for a long time and may develop septicemia or meningococcemia, where they may come to you and you may see this. This young man was in the EOS. Now remember, typically you're standing in EOS like this. He's holding on, okay? Why is he squatting? Why wouldn't he stand up tall? He can't. He can't. And you can stretch those hamstrings all day long. You're getting nowhere because it's a bony deformity. Okay? See how that looks like a fishtail? See how the middle, the central portion of the physis or the growth plate is very deformed, but the lateral portions are growing. All right? That's because it's the vascular structures in the middle are most affected by it. He cannot straighten those knees out any straighter than that. We knew at this point in time he was going to need further surgeries, that this was not going to be a one and done. We knew that. And he had been told that amputation, bilateral amputation, was the best choice by his surgeons up in Kentucky. He's actually back here for his final surgery now. Tried to get, anyhow, I'm going to go down that road. I'm just not going to go there. Okay, so he underwent deformity correction of one leg and then the other. So he got all the way through the distraction phase. So they did an osteotomy at the apex of the deformity to correct. They did actually, this is an example of the double level osteotomy. They did one here and they did one here. And you see we've got extra pins. It's not just two sets of pins. So they're distracting at different spots to correct at different spots, okay? So that we can get alignment. Right, so we did one leg and then he went home and healed and came back and did the other. And did the same thing with the other. And this was him about 6 weeks after, for the very first time in his life, he could walk. It's not pretty yet, but he's walking. We knew he was going to need to come back. This is him. Now his mom sent me these at different milestones. She would send me videos. So this is him in PE class. Talk about resilience. Bilateral amputation is what we've been told. We knew it was going to regrow. We knew that those joints weren't going to grow straight. So he came back, he had another surgery and alignment, and this was him last summer. He graduated high school. He is back for his final surgery with us right now, and he's non-weight bearing right now. So we couldn't get a great video of him running and walking, and I'll have to say they're not the most tech-savvy folks. They tried to send me their videos, but they have an Android and I have an Apple, and it wouldn't save to my computer, and they didn't know how to get it to me another way other than in Facebook Messenger. So anyhow, those videos aren't up there, but I can tell you he's walking up and down the stream. He's walking on rocks across the stream in those videos. It's absolutely astonishing. And he will be back, and I will take on my iPhone some videos of him doing stuff when he's weight bearing again. Anyhow, he's a great kid. Totally life altering for him. Okay, I've talked to you about guided growth, or hemiepiphysiodesis, right? It is a device inserted strategically to tether the growth plate or the physis and guide the patient's growth in order to correct the deformity. So I don't know about you guys, but I always thought if somebody's, and we used to call them, bow-legged or knock-kneed before we were PTs, right? If they had valgus or they had varus, I thought that was how they were, right? No, if you catch that as a child, you can absolutely correct it without big surgeries or osteotomies. It's a very, very basic surgery. I was at the International Limb Lengthening and Deformity Correction Conference in Miami that we hosted, and I was in the room with a group of surgeons from all over the world, developed nations and non-developed nations. And they were talking about 8-plate surgery or hemiepiphysiodesis surgery. And there were some surgeons from Uganda that were talking, they don't have access to the same hardware that we do. And they literally said they go to their hardware store, they get the screws and plates, and they sterilize it, and they are able to correct some really severe deformities through hemiepiphysiodesis. It's a basic surgery. It's a really simple surgery, but you have to have the knowledge of how to correct it. Anyhow, just a little caveat. It's a safe method used to accomplish this. So, what types of deformity can you correct with that? You can correct deformity in the long bones, such as genu valgum, genu varum, tibia vera, tibia valgus, ankle valgus. Now they're even doing some tethering of the spine in kids with scoliosis to tether the growth of the spine when you're having some deformity within it. That's pretty cool. So this is a kiddo with pseudoachondroplasia that we knew this was not going to be it for life. But he was 3 to 4 years old, and he had lost his ability to walk because he had so much pain in the knees. And his local doctor's response was, well, let's get him a wheelchair. Now, nothing against wheelchairs, and he may benefit from a wheelchair for community long-term ambulation. However, I don't think that's a solution. If he's got valgus and it's creating pain in his knees, let's think outside of the box a little bit. And really, hemiepiphysiodesis is not thinking outside of the box. It's a very well established surgery. So this is what his knees look like. You can clearly see the valgus. Okay, and it was creating so much pain. So they did 8 plates. Why do we call them 8 plates? See how when they first implanted, they were parallel. Okay, they use like a little device and they put the screws through it. So it looks like an 8, that's why they call them 8 plates. And then they leave it. And they let the body do what the body's gonna do, which is grow. And they're tethering the medial side because he had valgus. And they determined that it was in the femur, not the tibia, the distal femur, not the proximal tibia. So they tethered it there. And over time, he corrected. And they take them out when they're done. Can you guys see that better than I can? No, it doesn't show very well there. They took the right out prior to the left because it was corrected sooner. All right, but they both came out eventually. Now we knew that he was going to need to come back for deformity correction. Why? Because their bones don't grow straight. Their joints have a lot of deformity. And he did come back later, and he had the bigger surgery. But that extended his ability to walk. Because remember, we don't do those surgeries till they're about 8. He was 3. It gave him 5 years of walking and playing sports. And instead of a wheelchair, what he used for long distance ambulation or mobility was a scooter. So he could get, and a lot of our kids with pseudoachondroplasia and some of our achons love the scooter. Great, they're moving. right? Okay. Oh, a break?
Yeah.
Okay. All right, let me see. Okay, that's actually a really good time for a break, so 5-minute break, back here in 5.